Colleagues, ladies and gentlemen, medical students, doctors, postgraduates, faculty members, thank you very much for inviting me to speak to you. I resolved not to speak on a technical subject. I am going to speak to you on a very important subject, medical ethics. Medical ethics, really, is just a branch of general ethics, and therefore should not be divorced from the ethics of everyday life. A very subtle but beautiful definition of medical ethics has been given by a Professor Dunstein, who states that medical ethics can be defined as the moral obligations that govern the practice of medicine. Now let me speak on moral obligations. Let me just expand on this definition. Moral can be equated to ethics. Moral brings into our mind the question of right and wrong, good and bad, good and evil. And it enjoins that the physician is obliged, therefore, to do good to the patient, in the best interest of the patient. This is sometimes easy, but sometimes not so apparent, because a moral obligation, which is right in itself, can sometimes come into conflict with a different but equally righteous moral obligation in certain circumstances. You must remember that ethical principles are rooted in religious, philosophical, and socio-cultural traditions. And these vary in different parts of the world, in different countries, in different civilizations. Therefore, you can't have a unified code of ethics. It's very difficult to do so. But the basic instinct of what is really right and absolute wrong, as also the belief in the sanctity of human life, is present in all civilizations. I don't want to give you an idea of the history of ethics, but you must remember that the ethical principles have been thought of in medicine in ancient times as well. Hammurabi, who was the king of Babylon, was the first one to inscribe these ethical values on a stone or a stele. He inscribed them in his own script, and that is still present in the British Museum. You have Hippocrates in the 5th century. You have Charaka and Sushruta in the 2nd to the 5th century AD. And you have many others who have talked of ethics. I don't want to go into the details of the history of medical ethics. But the current description of medical ethics is given by two people. I don't think you'll know their names. Two doctors called Beauchamp and Childress, who in a book on medical bioethics said that there were 4 major principles in the ethics of medicine. And I want you to remember them properly, particularly the students. The first is beneficence, and its companion in arms, non-malfeasance. The second is patient autonomy, and the third is justice. Let me tell you what beneficence means. It's simple. It means doing good to the patient, acting in his best interest. Beneficence, of course, means that you need to have the technical know-how and the ability to look after your patient. And if you do not have that in a particular specialty, it is ethical to ask one of your colleagues to do that. But beneficence does not merely equate to technical expertise. Beneficence also contains human values. And what are these human values? These human values can be best summed up in the word humanism. These human values have unfortunately been pushed into the background by the advances of science and technology. Now, what is humanism, or humanity as we call it? It is the quality that enables a physician to care for his patient to the extent that he alleviates his suffering and gets him well as best as he possibly can. So humanism is an extremely important feature in beneficence. Now, you have the companion in arms of beneficence, which is non-malfeasance. Non-malfeasance means you will not do harm to others. There is a famous Hippocratic saying, primum non nocere. First of all, do no harm. That sometimes also is difficult. Let me give you an example. A patient has severe pain for which he requires morphine. He is elderly. He has many other comorbid states. Now, morphine also depresses breathing. You want to suppress his pain. At the same time, it is possible that while suppressing his pain, he might depress his respiration and make things worse. This is what is called a double effect. So every time you want to do something, please remember that there might be a double effect on this particular patient. The next most important ethical principle is patient autonomy. What does patient autonomy mean? Patient autonomy is that the patient has the right to decide whether he accepts the treatment that a doctor or a physician wants to give him. Of course, that is only possible if the doctor has explained everything that he wants to do, and the patient thoroughly understands what the doctor has said. That is patient autonomy. Today, medicine is centered around the patient. It is called patient-centered medicine. Once upon a time, it used to be paternalistic medicine. The doctor said, you have to do this, the patient will do this. It is not so any longer. But you must remember that an autonomous decision, that is the decision made by the patient to decide whether an investigation, whether a procedure, whether the treatment given to him is acceptable or not, an autonomous decision depends upon rational thinking. It has to accord with the patient's best interests and is based on critical reflection. If that is not so, it is really not autonomous. It's a point which is worth remembering. I've talked of beneficence. I've talked of patient autonomy. I want you to remember that there is very often a conflict between beneficence and patient autonomy. In fact, most medical decisions come about as a result of a balance between beneficence, doing good to the patient, and patient autonomy. The patient having the right to decide for himself. But I'd like you to remember that in acute medicine, emergency medicine, critical care medicine, whenever there is a conflict between beneficence and autonomy, it is beneficence that is to be selected. Let me give you examples. I'm going to give you quite a few examples to illustrate what I'm talking about. And I'm going to give you illustrations which are true to life, which I have experienced on my own. So I said beneficence is to be preferred in a critically ill individual, in an emergency, in preference to autonomy. I'll give you two examples. A young man, 28, with severe pneumonia, is admitted to the critical care unit. He's desperately ill. He's blue. He has marked tachycardia, marked increase in his respiratory rate. His oxygen saturation is approaching 70. He has a tachycardia of 140 per minute, but he's conscious. He's very young. He has a wife, he has a small child. He needs to be intubated and ventilated, urgently, immediately. He refuses. He says, I have a right to refuse this treatment. Do anything to me, doctor, but I will not be ventilated. I don't like the machine. I will not be intubated. I will not have this tube in. I will not have the machine. We spent 5 to 10 minutes trying to explain to him that it was very important for us to do so if we were to stay. He refused. His wife tried to explain to him. He refused. What do? Do I listen to him and say it's patient autonomy? He has a right to decide what is good for himself or not. What should I do? This is a critically ill person. I told you, here beneficence takes place over autonomy. So I tell my registrar, just give him a dose of midazolam, quick intubate and quick ventilate. We did that. After a great deal of difficulty, after many days of struggle, the patient survived. He went home, and whilst going home, he said, I'm so sorry, doctor, that I told you that. I'm very grateful that you did what you had to do. So there you go. Let me give you another example. The doctor who was depressed, she wanted to kill herself, and she very nearly did. And she comes with a note and with a friend saying that this lady has made it her express wish that she does not wish to be resuscitated. Here again, you have acute and you have a problem between beneficence and autonomy. What do? Here again, beneficence takes place or takes pride over autonomy. The patient is treated again, she survives, and again she's very happy that this is so. But what happens, however, in other patients? Before I tell you that, why did these patients make such autonomous decisions? You must remember that such autonomous decisions in patients who are seriously ill are not truly autonomous. Why do they say such things or believe in such things? It's fright, it's anxiety, it's panic. It's the fear of doctors, fear of hospitals, fear of machines. Therefore, though you respect patient autonomy, it is not necessary that you respect a patient's decision at a particular point in time. It's very important to remember that. But in cold cases, a patient has cancer. The doctor says you will need chemotherapy or you will need radiation. The patient says, no, I don't want chemotherapy. You explain, sit down, tell the patient, tell the truth, explain to the relatives. The patient says, I'll think. I say, all right, don't make up your mind, think it over for a long time, and then come back to me. The patient comes back to me and says, I made up my mind, doctor. I've talked with all my friends and relatives, and I've made up my mind that I don't want chemotherapy. This is a sort of situation where an autonomous decision has to be respected. You may try and convince the patient of your view, but it's a cold, calculated problem in which the patient has spent a lot of time thinking about it, consulting his friends, consulting perhaps other people, and he has made up his mind that I don't want this. That is an autonomous decision you would have to respect. But there are many grey areas in this sort of a situation between beneficence and autonomy. Let me give you another example. These are true-to-life examples, mind you. There is a lady who's been a patient for a long time with diverticulitis. She's had repeated attacks of diverticulitis. And I tried to tell her that I think it's high time you have this dirty piece of colon, sigmoid colon, removed. This is no doctor. I don't want any surgery. We will continue with medicines. I've had so many attacks and I'm well. We'll carry on. It's an autonomous decision. You keep quiet about it. All right, accept it. Now a day comes when she has a perforation. A perforation in a large bowel, an abscess and a little generalized peritonitis as well. This is going to kill her. She says again, no, my decision is I don't want surgery. What do? Do I try and change this autonomous decision? Yes, I think I should. I think I should. So I sat down with her and we discussed it at great length. And ultimately, she said, yes, but you can only do that if there is a bond between the doctor and the patient. If the patient trusts you implicitly, if the patient knows that you're acting in her best interest and realizes perhaps that she's wrong, and the doctor is right. This is a condition which is called soft paternalism. The doctor changes the autonomous decision for the better in the interest of the patient. And give you one more classic example. This is again a true to life example. This is a friend of mine. He has a family history of Alzheimer's disease. So many in his family had Alzheimer's. He's beginning to lose, forget things. And he's worried that almost certainly he's going to get Alzheimer's. So he tells everyone around him, his relatives particularly, that if I develop Alzheimer's, and if I get a serious illness, then you are not to do anything about it. Right? So it actually happened. Over a period of time, he developed Alzheimer's. But he's a very happy Alzheimer's. He loves art. He loves his drink in the evening. He loves to go out to meet people. He forgets everything. He can't remember anyone except his wife. He has advanced Alzheimer's. Now he gets an acute urinary infection with urinary sepsis. E. coli present in the blood, and he's very ill. What does one do? Do I respect his decision, his autonomous decision, that if I fall ill, don't do anything about it? My answer is no, here again, for many reasons. For many reasons. Would this man have known that when he had Alzheimer's, he would be in such a happy state of mind, living a very happy life, content and happy life? No, he wouldn't have known that. Would he have realized at that point in time that he would have been as comfortable as he was before and living a more or less normal existence from the point of view of well-being? No, he wouldn't have done. Was it possible that he might have changed his mind towards the end if he knew that this was going to be? No, again. So there again, beneficence prevails. You treat the patient and he's back again to his usual happy self. So there are many such grey areas where you have a balance between beneficence and autonomy. And most medical decisions are this balance. And you have to bear this in mind. What is the third one? The third one, which has been defined as a major ethical principle, is justice. What do you mean by that? You mean that you do as much right as possible and as little wrong as possible. And if you can't do what is absolutely right, you do what is as little wrong as you possibly can and as less wrong as you possibly can. This can be difficult. When we set up the tetanus ward at the JJ Hospital, we had 8 beds, I think, yes, 9 beds in fact. And we managed to get 3 ventilators. In those days, most of the patients with tetanus were critically ill. Now, what do I do with the ventilators when more than 3 people need it? What do I do? You would say, just use it on the 3 most ill people. But how do I know that 2 days from now, the other person will even become more ill? What is justice here? Yes, of course you do it on the 3 worst people, but you are in a conflict. Fortunately, in those days, we managed to shift such very ill patients to another hospital where they were kind enough to treat them free on ventilators. But I'm just giving you an example at point. Also, I think it is important for physicians to be involved in the ethics of resources for medical care in the society they are working, so that equitable care can be given to all members of the society, particularly to the poor. But unfortunately, this is not so. This is decided by government and by the bureaucrats. The doctors hardly ever come into the picture. For example, it is just to develop hospitals like the SAN, the JJ, the KEM to the best possible extent, to make them centers of learning, centers of research, and centers of treatment, rather than have 5-star hospitals. It is also very just not to spend money on expensive drugs, but to look at preventiveness. There's so much good can be done. Water, nutrition, housing, sanitation, education, particularly for girls. That again, it would be unjust not to neglect these factors and to build again large hospitals or take on expensive drugs. You could do far more good in developing countries, far more justice to people in developing countries than by using expensive methods. So that is as far as justice goes. Now, you need to know a few other points or a few other important ethical principles. The first is communication. It is extremely important, young boys and girls who are students here, to communicate with them, to tell the patient what is happening to them, what you are going to do about it, what you are planning to do about it. In this way, you make the patient an ally. He joins forces with you, fight his disease. And this is particularly very, very important in critically or in seriously ill people. When you build a bond between the doctor and the patient, you build what is called faith of the patient. And faith, ladies and gentlemen, is an important factor in healing. It is a powerful force. It is a force which you cannot weigh in a balance, nor can you test in a crucible. But believe you me, it sometimes makes a difference between life and death in a seriously ill patient. So communication is extremely important. Don't forget, in these days, you must communicate with the relatives. That is equally important. You must tell them everything that is happening. It takes a lot of time, it takes a lot of patience, but it is important to do so. It is only then, that legal problems and legal issues are very often prevented. But if you don't communicate with the relatives and tell them exactly what is happening, the truth, why you are doing this, why you are not doing this, particularly again in seriously ill people, you will have a problem. And for those who are postgraduates, and those particularly who are dealing with very ill people, I suggest that you also communicate with yourself. And how do you communicate with yourself? Well, I communicate with myself. I deal with very ill people. I communicate with myself by writing lengthy notes on patients. Every 3 or 4 days, I write a very lengthy note on what has happened to them, why it has happened to them, what have I missed out, what should I have done, everything. What do I anticipate? What are the problems that are likely to occur? How am I trying to prevent them? You must remember one thing, as the old doctors, particularly when they are looking after ill people, you must be one step ahead of the illness, which means you must be able to anticipate what is likely to happen to your patient. Only then can you become a good physician. Please remember that. So communication is extremely important. What's the next important thing? It's confidentiality. Confidentiality is important. You know that even a conversation in the consulting room between a doctor and his patient is confidential. Even the court cannot ask you to divulge that. It is that. But confidentiality is important to a point. If the confidentiality is going to injure other people, then that confidentiality has to be broken. A patient with HIV says, I don't want my wife to know anything about this. That's wrong. You can't keep that confidentiality, and you have to tell the patient that I'm sorry, I can't keep that as a secret, because it's going to injure other people. So confidentiality is the other. I consider charity also as a very ethical principle, particularly in our part of the world. It is wrong for a doctor not to see a patient in his room because he cannot afford his fees. I think that is wrong. There is a very famous saying by an old ancient doctor in an old ancient book when he writes, do not enter the temples of science with the soul of a money changer. So it's very important to remember that. Is there any other important ethical principle? Yes. Honesty and integrity. Remember I told you that medical ethics is a branch of general ethics. And you cannot divorce it from the ethics of everyday life. Honesty and integrity is part and parcel of your everyday life, and you must make sure that that seeps into your dealings with your patients as well. And finally, care over human rights. I don't know if you know, in Nazi Germany, during the Second World War, they perpetrated the most heinous crimes on human beings, where they made dreadful experiments on human beings to find out what was happening. And from that point in time, there was a large meeting and a conference in Geneva, which gave the Declaration of Human Rights, where patients' human rights are to be respected. When you do trials, for example, drug trials, for example, it's very important to make sure that poor people who are prepared to enter this trial, everything has been explained to them. Many a poor person will enter the trial because you're paying him the money for it, perhaps. So these are important issues to be remembered. Please remember that. Protect the patient's human rights. So these are basically ethical problems in relation to the doctor and the patient. Doctor-patient relationship. But there are important problems also, if you look at it, in relation to the medical profession as such and the society at large. Does the medical profession practice medicine in society in an ethical manner? Are there any deficiencies or faults which become unethical in the long run with regard to the practice of medicine by the physician, by the profession as such? Yes. The answer, it is indeed so. All of you know that technology and science has changed the face of medicine. Medicine has been able to do feats which would seem miraculous 60, 70 or 80 years ago. This is an inalienable fact. You all know that. I don't need to give you examples of this. But there is a paradox. The paradox is that in spite of what medicine is able to achieve today, there is a sense of distrust, disillusion, and even antagonism against the medical profession and against doctors. The paradox is doubly striking. Say, for example, in the 1950s and 60s, when science just hovered in the background and medicine had not done great things as it is doing today, the medical profession was held in very high regard. And the doctor's image was second to none. Today, when medicine has achieved so much, when medicine has pushed the frontiers of medicine so far ahead, the medical profession, believe you me, ladies and gentlemen, this is all over the world, is not held in that high regard. And the image of the physician has been badly tarnished. Why is this so? Why is this so? This is so because medicine, perhaps as straight from its path, has lost its goal. The mechanization of medicine, the hubris of its science and its technology has submerged the art of medicine, has robbed it of its very essence, what we call the raison d'etre. It's humanism. The doctor today, ladies and gentlemen, believe you me, relates more to the machine than to his patient. The machine has become the interface between the doctor and the patient. And unfortunately, the patient is also made to relate more to the machine. The patient says, I want an MRI, this is necessary, I have a headache, I must have an MRI. So what happens? The bond between the doctor and the patient is lost. And the bond between the doctor and the patient is the very core of medicine, is the heart of medicine, clinical medicine. So when you look at that, collectively speaking, the medical profession also has lost its bond with society, has lost its connection with society. And that is indeed a very sad state of affairs. What are the other drawbacks of contemporary medicine. The other drawback of contemporary medicine is the fact that medicine has become a business instead of a profession. Money is the root of all evil, particularly in this profession. Doctors are more interested in what they earn than in the patients that they are looking after. Believe you me, this is true. I'm not exaggerating. And that again is a sad state of affairs. I ask you, what can be more unethical? When a doctor sends a patient from one person to another, from one specialty to the other, not because it benefits the patient, but it benefits the specialist. What can be more unethical? When a general practitioner wants a cutback from a consultant because he's referred a patient away. So these are great unethical practices. And as young people here, I would beseech you to eschew them, to repel them, to have nothing to do with them. What's the other disadvantage of contemporary medicine? The other disadvantage of contemporary medicine is the cost of medicine. The cost of medicine today is phenomenal. It can ruin a middle class family, particularly if the patient is seriously or critically ill. And why is that so? It is so because the doctor, the physician, the clever physician is more immersed in the science than in the art of medicine. It is technology which directs his approach to the patient and not his clinical judgment. History taken is a forgotten art. Nobody listens to the patient. Nobody talks to the patient. Physical examination also is a forgotten art. Your machines. The physician forgets to use his eyes, his ears, and his hands. With what result? That he prescribes expensive investigations when simple tests can be are enough. Or prescribes very expensive drugs when just simple remedies would suffice. And then you see, therefore, that adds to the cost of medicine. Is there any other drawback in contemporary medicine? Yes. It is the institutionalization of medicine. What is meant by the institutionalization of medicine? Give you a practical example. In South Bombay, there are some 8 MRI machines in a radius of half to 3/4 of a kilometer. What happens? The poor man who's in charge of the MRI machine is told, what are you doing? You're not getting income for the hospital at all. This is such an expensive machine. I mean, we must have some turnover. What happens? The machine is made to take patients very often when there is no reason for it. Patients become cannon fodder for the machine. That's certainly unethical. But that is what is meant by institutionalization. So these are some of the effects of contemporary medicine. I've always asked myself, why have these defects come in? I feel that these defects have come in because there is a fall in the sense of values in this world. All over the world, not just only in this country. And it is the lack of sense of values which has also crept into the medical profession. You see, you cannot have an island of virtue, the medical profession, when surrounded by a sea of corruption. Sooner or later that island is going to be swamped. I'm not giving you an excuse, mind you. I'm just giving you the pathogenesis of what is happening. But as a profession, we must resist that. It is a remarkably different profession from any other profession. And it is our duty, and particularly the younger people today, it's their duty to resist that and to stand up for ethical values in the profession. I would now like to give you some other information about which perhaps you are not aware. When I was teaching at the JJ Hospital, I used to make it an absolute rigor, absolute necessity for every registrar of mine at least to read a book by Ivan Illich. The book was titled Medical Nemesis. The second edition of the book is called Limits to Medicine. Now, what are limits to medicine? And what is medical nemesis? Ivan Illich said, and he starts a small little book like this, that the medical profession, in my opinion, has done more harm than good. This is his first sentence, something to that effect. Ivan Illich is not a doctor. He's a great sociologist. He's a professor of sociology in Mexico. And I think this statement is unquestionably exaggerated, particularly for those of us who have done medicine. But there is some truth in what he has to say. He says the medical profession has three great problems in relation to medical society. The first he calls clinical iatrogenesis. Iatros is the making, or genesis is the making, and iatros is the physician. Physician-made disease or hospital-made disease. Up to the 1900s, there were very little pertinent cures in this. But now we have so many other medications, so many powerful medicines. And they all have their side effects. So he quotes chapter and verse from peer-reviewed journals to show the amount of damage, the amount of injury, the amount of problems, and the amount of deaths caused by medications prescribed by doctors. Now, of course, we must remember there is no potent medicine in this world which does not have some side effects. So you can't wipe out iatrogenesis from current medicine. But at least it behoves us to get up and realize that when we prescribe something which has dangerous side effects, we have thought about it very deeply, and we have to make up our minds that the good it is almost likely to do is much more likely than the problems that it might cause. The one, therefore, what calls is clinical iatrogenesis. The other thing, which I didn't know, I knew this before, till I read this book, he called social iatrogenesis. And that's interesting. He says social iatrogenesis is that the medical profession so conducts itself that it has made citizens of a country or of a city or of whatever place it is very dependent on it. So that for the smallest thing, he goes to the doctor and often goes to the hospital. This is social iatrogenesis. It's good for the profession, it's good for the hospital, but it's bad for society. The smaller things society must look after itself and not depend necessarily on the doctor. And the last thing which Ivan Illich writes is also very important today, in today's times. It's called cultural iatrogenesis. What is cultural iatrogenesis? It is the inability of society and of individuals today to accept the inevitability of suffering in this world and the inevitability of death. Which means that modern medicine today fights death right up today. At any cost, the patient must be kept alive. This is sad, because this is not correct. You cannot prolong the act of dying. Of course you relieve the patient. Of course you relieve the suffering, but you cannot wipe out, expect the patient's suffering to be wiped out if you are ever hard to die. Suffering is part and parcel of our existence, as you know. And death is inevitable. It is the most certain thing in life. So these are the three things that he mentions. I told you about the various problems of contemporary medicine in relation to society just a while ago. But I would like you to remember one thing, that a relationship is a two-way affair, and that holds also the relationship between the medical profession and the society at large. And I want you also to realize that to an extent, society is also responsible for some of the attitudes of contemporary medicine. Society expects too much from medicine. There are limits to medicine, and there will always be limits to medicine now and in the near future. You all know that. There are very few diseases that medicine can cure. There are many which it can alleviate or relieve. Now, an ill individual expects that his patient has to get well. Medicine is so powerful, it must get well, the patient must get well. And when the patient does not get well, health gets loose. How did he not get well? He should have got well. Therefore, he vents his anger both on the doctor and on the institution. The institution can fight him, but the poor doctor cannot easily fight him. So what happens? The doctor wants to protect himself. Therefore, he asks for so many tests which are often not necessary. Why? He doesn't want to miss out on it. And that's bad medicine. Also, worse still, if there is a patient with a real emergency, where something has to be done in an emergency manner, it's an emergency, he's afraid to do it. If the patient dies, what will happen? They will say, you're responsible for his death. So worse still, he is afraid to use medicine or practice his medicine as he should. So it's important to remember that. I just want to touch now on euthanasia. Euthanasia consists of intentional killing of a patient who says, oh, doctor, I'm suffering too much. You must get me out of my suffering. Please kill me. It also consists of what they call now as the assisted suicide. And finally, it consists of homicide, when a decision to kill a patient is taken by proxy, by an individual who is not the patient himself, by somebody else outside, who says that, look, this patient, he cannot bear the suffering, and he's suffering too much, his quality of life is so much, you must put him out. Kill him. There are many people who support euthanasia because they say it is beneficial. You're helping the patient, relieving of the suffering. But I think that's wrong. It's very wrong for the simple reason that it means that you have no respect for the sanctity of life. In today's time, pain and suffering can be relieved almost to a great extent. So it is not right to take life just because the patient says that he's suffering. It's your duty to relieve that suffering. It's important. In the West, in some countries, euthanasia is now legal. There are many, even in this country, who say that to die with dignity is important. They equate dying with dignity as if it is important to have euthanasia to die with dignity. This is indeed not so. You must remember that if euthanasia is legalized in our part of the world, I think it will throw open the floodgates of murder. There are many countries which have legalized it, but even with many safeguards, there have been many problems, even in those countries. Can you always quantify suffering, I ask you? Can you quantify it? Different people, with different methods, different ways of bearing suffering. Can you quantify it? Is not suffering to some extent a state of mind? And cannot this state of mind be influenced by changing social customs and social laws? Can there be enough doctors, physicians in our part of the world who have the knowledge, the experience and the Australian wisdom and perception to in the cause of euthanasia for patients who say, I cannot bear this suffering, please get rid of me, get rid of my suffering by killing. You must always remember, it is a very important issue, mind you, and it's going to come to the fore, particularly in future years. You must always remember that when you legalize a condition called euthanasia, is the good that you are likely to do outweigh or outbalance the harm? That's the point, which is a crucial point that everyone must remember. Finally, I must say a few words on future medicine. The future is going to raise great problems, both with regard to medicine and ethical problems. As you know, the science of genetics, the science of reproduction, procreation, is going forward at a terrific pace. And it has outpaced the ability of the medical profession to satisfy or to answer the ethical problems that have arisen because of it. Bioethics is an uncharted sea, and it is important that you map the sea if humanity is not to be shipwrecked on the shoals and reefs. This is important. You know, there was a big conference in a big group of scientific people, not one but many, which said that the human genome should not, research on the human genome should not in any way harm the human being. But is that likely to happen? Is it happening? Even today, I don't know if you are aware of it, there is a great demand in the United States for what they call designer babies. They want to know which gene is responsible for blue eyes or brown hair or blonde hair or whatever it is, and why should not these genes be given to the child that they are bearing. You must be aware of the fact that it is possible to clone human beings. It is banned. It is banned, but you never know what can happen in future years. It can happen surreptitiously. You might be, for example, cloning a Frankenstein, a monster. What alarms us most is genetic bioengineering. Are you aware of the fact today that scientists have been able to produce hybrid animals, genes from one species being inserted into another species so that you get a hybrid animal? Some have even experimented by using genes from human beings into animals, so they have some sort of creature coming out. It is possible, therefore, that scientists might want to have genes which have peculiar qualities and which are not present in human beings today. Shall I give you an example? A gene which allows you to bear tremendous heat. A gene which allows you to bear tremendous cold. Why? Because that might not be necessary if you want to make a colony on planets today. So this is indeed frightening. You see, we have evolved from a single cellular state to our present state, either through genetic drift or through Darwinian selection. It took millions of years to be Homo sapiens as we are today. But if bioengineering really takes effect, you might change the human species in another 100 or perhaps 1,000 years. And you might make a species which is completely different from what you and I are there today. And that might be indeed a frightful thing. This might sound to you as science fiction. But remember, the science fiction 100 years ago or even 75 years ago is coming true today. Therefore, ladies and gentlemen, it is the duty of the medical profession to ascertain that ethical laws are brought into place which do not allow research, medical research, to tamper with the human genome. Of course, you must encourage research. You must encourage free research. But at the same time, there must be a balance between research and human values and human rights. If this is not done, then it is possible that mankind will be plunged again into a new dark age, made even more sinister by the lights of perverted science. Thank you.